On August 2nd of 2015, I had an experience that no physician and certainly no family member would want. We were on a family vacation in a rural Colorado mountain town, and we had just witnessed our 6-year-old son having a terrible biking accident. By the time we got to him, he was laying in a crumpled heap at the bottom of the hill, and he clearly had an abdominal injury and possibly even internal bleeding. As my wife scrambled to find coverage for our young children so that I could take him as quickly as possible to the nearest emergency room, I realized there was no emergency room, no CT scanner, and not even an ambulance in this small town. So I found myself driving 28 miles through 2 valleys along winding roads to get him care. And along the way, I realized that there was no cell phone coverage beyond town, and I was able to get one phone call off to the emergency room in which I asked that they have a surgeon and a CT scanner ready for us because we were coming in with a critically injured child. The line disconnected before I could get their answer. And so I drove on and tried to comfort my son and realized that we were in a precarious situation. If his situation worsened significantly while we were driving, I really wouldn't have any options. I had no way to contact help, and I had no tools to help him with. Fortunately, we arrived at the emergency room, and the team was waiting for us. After completing some paperwork, we were able to get the CT scan, and sure enough, unfortunately, he had ruptured his liver, and he had significant internal bleeding. The bleeding was held in check only by a razor-thin layer of tissue encapsulating the liver. And as I sat with the emergency room doctor and the surgeon, my wife arrived in a borrowed car, and we discussed what should happen next. We had several options. We could observe Benjamin there and hope that he got better. We could take him immediately to the operating room, or we could transport him to specialists at the Children's Hospital over 300 miles away via air ambulance. But the weather was growing bad, and there was some real decisions to be made. Ultimately, though, we decided he needed to be medevaced, and soon my wife and son were flying to the nearest Children's Hospital, and I was left to pick up the pieces. So there ensued a ritual that I'm sure anyone who's taken a family member or a loved one to the hospital would be familiar with: the completing of paper documents, signing paperwork, providing insurance cards, and ultimately I requested a copy of my son's records so that the next physician in line would have what they needed. And somewhat ironically, I was provided with a big stack of Xerox papers in a manila envelope and one CD-ROM with a CAT scan on it. It was ironic because here I was in healthcare. I use electronic health records all day, every day, and now I would be transporting a paper form of my son's records to the next point of care. I also began to have questions. Had we done the right thing? What would Benjamin's outcome be? Would we be observing him, and if so, for how long? Would he be able to play sports again? Would he be able to lead a normal life? Would he even survive the transport? And so I did what every good physician does in the modern age. I sat down and I Googled the information. And what I discovered initially reassured me. I found several studies that showed that there was a clear protocol for managing this case, and we were currently following it. But then I began to read the studies, and what I realized was that these studies were based on a dozen to just a few dozen cases. Certainly not the thousands of cases I knew to have occurred in this country over the last few decades. And so I realized that our entire treatment plan for my son was based on statistically insignificant results. Now, I practice internal medicine and pediatrics, but my specialty is called medical informatics, which is the study of the use of information in healthcare. And when we use information in healthcare, we find that there are a number of situations where we think about what should be. And when we're thinking about what should be in healthcare, I applied that then to the situation with Benjamin. And what should have been is that we should have had, the moment I called the emergency room, I should have been able to give them a code so that they could pull up Benjamin's lifetime health record, and they could find everything going on in his health so that by the time we arrived in the emergency room, we were registered, his medication doses could have been calculated and drawn up, and the CT scanner prepared for his arrival. What should have been is that when we sat together with the physicians to try and decide what the plan could be, we should have had the CT scan shared with the specialists at the Children's Hospital to consider what the best options might be for his treatment and the best evidence, and to make that decision together. And also what should have been is that my wife and I should have had access to those records so that we could have seen what was coming next and provided the additional information that only parents know about their child's health. And finally, what should have been is that these excellent doctors, and they were excellent doctors that took care of Benjamin, they should have had better information to go on. Rather than guessing based only on a few dozen cases, every single case of liver injury of this type in the United States should have been available as evidence for the best treatment plan for Benjamin going forward. And so if we think about what should have been, why doesn't our healthcare system work this way? Well, it turns out that the Institute of Medicine has been thinking for some time about this problem, and they propose that we create something called a learning health system. A learning health system is one in which, as information is gathered from physical exams and histories and tests, and treatments are given like medications or surgeries, the outcomes, that data and the outcomes of those treatments are gathered into a secure data system so that those results can be available for research and available to decide what are the right next step to take with each patient and in each situation. So we would all agree, I think, that the learning health system is something the nation could benefit from, and we would also probably agree that we're far from achieving that at this point. Speaking only of convenience, the healthcare system is probably one of the most least convenient things that we access for ourselves and our families. And we could buy a plane ticket or buy something online or do a banking transaction many times over before we could ever get in to see our physicians. Worse than that, if you've ever tried to request your medical records, you will realize that you've got to wait a period of time and often pay for those records, because it turns out that patients don't actually own their own medical records. The Health Insurance Portability and Accountability Act, which protects our privacy, says that the source of the medical record is the one that owns it, and the patient is entitled to a copy. Finally, we recognize that healthcare costs are high, but not everyone realizes that healthcare costs in the United States are twice that of most other nations in our peer group. But at least we console ourselves by saying that we're getting the best healthcare in the world. But it turns out we're really not. Most Americans have worse health outcomes and worse care, access to care, than our peer nations around the world. And finally, we have the problem of the ever-increasing knowledge base in healthcare. In the last decade, there are hundreds of new diagnoses and conditions and thousands of new medications and treatments. A newly minted board-certified physician who remembers everything they were ever taught and dutifully reads 2 journal articles every night will be over 1,200 years behind after only their first year in practice. That's a lot of information to keep up with. And so recognizing that we need this learning health system, the first step in building the learning health system became the aggregation, the accumulation of data so that we could move it from one place to another effectively. And in 2009, the stimulus legislation made a large investment, a $30 billion investment, in modernizing America's healthcare system so that we might have electronic data to move from one place to another. The vision was to create the interstate highway system for health information. Unfortunately, what emerged was really a situation where every doctor and hospital bought a very expensive but proprietary electronic health record system, and those don't talk to one another so that the data can move. So the result has been that instead of having the interstate highway system for healthcare, we bought everyone an expensive car, and those cars only run on toll roads owned and operated by the vendors themselves. Fortunately, however, something different happened here in Oklahoma. Here in Oklahoma, a group of healthcare stakeholders came together, people from physicians, hospitals, from insurance plans, from employers, tribes, and universities, and many others came together and said, why are our health outcomes so poor? Why are we ranked near the bottom of all the states in the nation? Why do we have such high costs that we can't get under control? And we resolved at that time that we wanted to do something about it, that we wanted to build something that has not existed before, to create something that would be brand new to help health in Oklahoma in particular. And that project has become My Health Access Network. And over the last 8 years, more than 1,000 individuals have donated tens and thousands of hours of their time, first to design and then build and now sustain My Health Access Network, which connects 1,500 locations of care across the state of Oklahoma. And every day, for patients who go to emergency rooms, see their doctors in clinics, or admitted to the hospital, are served by this network. as their physicians are able to log in and pull up their full health record to deliver higher quality care at lower cost to these patients. And this investment in infrastructure has begun to pay off. For example, in 2012, over 200 primary care providers in Oklahoma got together with our local insurers and with Medicare to deliver care in a new way. And that care delivery was based on transforming the practice, but also based on getting paid in a new way for health care. And the results were striking. In the first 3 years of the program, an average of 5 to 7% per year were saved in health care costs, as well as a dramatic increase in quality. All told, over $100 million have been saved on this relatively small patient population. The rewards have been significant because now Oklahoma has been selected to participate in a statewide model in which nearly 700 Oklahoma physicians and hundreds of thousands of Oklahoma patients will get to participate. This model will bring in $500 million in new revenue to the primary care infrastructure in Oklahoma. And if the current trends hold, more than twice that amount of money will be saved. In addition, Oklahoma has been chosen to be, MyHealth has been chosen to be the hub for the Accountable Health Communities program here in Oklahoma, which will link physicians and hospitals with those social service agencies that meet the needs of our most vulnerable population, because we have a lot of patients who simply can't focus on their health care because they're too busy trying to get enough food to eat or shelter or a safe place to live. Finally, MyHealth is working together with the George Kaiser Family Foundation to connect the early childhood intervention programs in our communities to one another so that they might coordinate the services they deliver better and evaluate the impact they're having on those families and children that they're serving. So we've made pretty good progress here in Oklahoma in delivering the infrastructure for a learning health system, but is it enough? If you take a look at this slide, what you see is a map of the United States. And of course, you see in red there are lots of patients in Oklahoma, but we also have patients all over the United States who've received care in Oklahoma, and yet their home addresses are somewhere else. So those home addresses being somewhere else means that those patients they have their records here in Oklahoma, but not where they live. We need a model that moves patients' records to where they live. And it turns out while MyHealth was being developed, a network, other groups like MyHealth were also emerging, and those groups have come together to form something called the Strategic Health Information Exchange Collaborative. There are more than 50 of us now, and we cover 200 million patients nationwide. Those 50 organizations have agreed to create something called the Patient-Centered Data Home. And in the Patient-Centered Data Home, all of those patients' records that belong in another place but exist in Oklahoma will be sent from our network in Oklahoma to the place they live. And likewise, for those patients who live here in Oklahoma but get care elsewhere, their records will be sent automatically here so that they can come home to their primary care provider and their other doctors. So this Patient-Centered Data Home is live and active and exchanging patient data all the time. We now have 10 states connected, and there are more than 200,000 patients have already been served. So with the creation of this infrastructure for the learning health system, by beginning with the local regional collaboratives where we can see and meet and begin to trust one another and exchange healthcare data securely, and then the addition of the connection of those local regional networks to this nationwide effort called the Patient-Centered Data Home, we feel like we're on the right track to developing and rolling out a true learning health system here in America. But now it's your turn. As patients, as family members of patients, as caregivers, it's time to start asking your doctors and hospitals whether they're connected to the network, whether they have access to your record, and whether they've looked at your medication list to make sure they know all the medicines you're on and not just the ones you remember to tell them about, to make sure that they know all the treatments and other doctors you've seen so they can better coordinate your care. It's time for you to expect more from your health system. I know that Benjamin and I do.